My name is Dr. Sindhu Mohan Kumar, and it is with great pleasure that I would like to present my presentation today for the Straumann Young Professional Program. The case that I will be presenting will be of the immediate implant in the anterior aesthetic zone with replacement of anterior crowns. My patient initially presented to me with an abscess on tooth 2-1 due to an external root resorption. She had initially met with an endodontist who had told her that this tooth was no longer salvageable, and hence she had come to me for the extraction and replacement with a dental implant. Lucky for us, this patient presented with a very low smile line, but that being said, she was a very nitpicky patient in the sense that she would actually lift her lips up with her fingers and actually point out all of the little problems that she was not happy about to me. She had also mentioned that she was unhappy with the crowns in her anterior region from 1-2 to 2-2, and she would also like to look at having them replaced when we are done with the dental implant process. So I had to take a few things into account, not only the anatomy of her existing teeth and the improvements that she had wanted to make, but also of her soft tissue architecture as well. From here, we can see that she actually has got a very good amount of thick gingival phenotype as well as a good soft tissue architecture, and I wanted to do everything in my power to kind of preserve that for her. That being said, she did present with a black triangle between her 2-1 and 2-2, and I had to take this photo to make it known to the patient that this black triangle, we will do our level best to keep it as it is, but there is also the risk that it may slightly worsen after surgery, and it was important to keep the patient's expectations in check. So this was her initial radiograph when she had presented to me. As you can see that there was an area of periapical radiolucency with the 2-1, but lucky for us that area of periapical radiolucency was quite limited, and it meant that the infection was not widespread and was actually acute in nature. Although not ideal for an immediate implant placement, it does not contradict it completely, though it makes the procedure that much more challenging as well. So my treatment plan was essentially to extract the tooth 2-1, go ahead with the placement of an immediate dental implant, undertake soft connective tissue grafting in order to preserve her soft tissue architecture, and if permitting, I would also like her to leave the surgery with the placement of an immediate temporary screw retain restoration. I had also undertaken the SAC classification in order to assess how easy or difficult this case may be prior to starting. And from the SAC classification, I could see that this was a case that presented with its own sets of challenges that I had to be a little bit careful about. I also undertook her CBCT evaluation, and upon doing the CBCT evaluation, I found that although we did have a good amount of bone in order to place in our dental implant, she did present with a thick 2mm labial plate. But because of the architecture of her labial bone, wherein it was actually dipping inwards towards the apical region, I had to select a slightly longer implant in order to ensure that I had sufficient apical engagement for my implant to give me primary stability. And because of this, I had actually opted to go in for a Straumann BLX 3.5 by 16mm dental implant. Coming to my surgical protocol, my first step was actually to undertake a traumatic extraction. So what I had used was periotomes to actually release the soft tissue away from the root structure. I then used an extraction forceps to remove out the crown, and then I also used luxators to atraumatically remove out the root structure away from the bone. I had managed to leave the labial bone intact, and I was pretty pleased about that. So the next step was then for me to undertake socket degranulation. I wanted to ensure that we did not leave any sort of granulation tissue behind because the patient did present with a periapical pathology. So I did use Gracie curettes along with copious saline irrigation to irrigate the area and clean out the area of any granulation tissue. My next step was then to actually undertake the implant placement. I chose to go in with guided surgery for this case because of the difficulty in the architecture of her bone architecture essentially. And I had used the Straumann co-diagnostic software to plan out and fabricate my surgical guide. I also used the Straumann guided surgical kit to place in my dental implant following the guide. And upon placement of the dental implant, this is how the implant placement looked like. It was in a very favorable palatal position. You can also see that the thick labial plate was also left intact, which I was quite pleased about. And we had ended up going in with our planned implant of 3.5 by 16 millimeters. I had managed to record an ISQ reading of 74 to 76 all around the implant, and I was quite pleased with that, which meant that I could actually immediately load my implant as well. I then proceeded to graft the jumping gap utilizing allograft, which is my material of choice, and over that place a collagen membrane in place. I then also wanted to undertake connective tissue grafting, which I was going to do upon fabrication of my immediate provisionalization, which was the next step that I had done. I usually tend to get my lab to fabricate a PMMA shell for me following the existing architecture of the patient's tooth, and then I connect that PMMA shell to my temporary coping or temporary abutment. And then I will also undertake sculpting of the composite in order to build my soft tissue architecture and preserve that soft tissue to ensure proper gingival support is present so that my tissues don't collapse and I can build a very nice, beautiful emergence profile in the area. So my next step upon fabricating the provisional was to actually harvest my connective tissue graft from the palate, and once that was done, I undertook a tunneling method to actually place in and secure my connective tissue graft, as you can see from the 5 Obrelon sutures that I have used here. I also ensured that my provisional crown was freed of any occlusal contacts in maximum intercuspation as well as in lateral excursive movements, as if any contacts were present during those occlusal positions, it would actually hamper the integration of my dental implant. Now at 2 weeks post-op, my patient came back for the suture takeoff appointment. As you can see, there was a dressing that was placed there, and my dressing of choice is actually periacryl. So immediately upon removing of the dressing as well as the sutures, this was how the tissues looked like, and I was quite happy with how they looked, as they looked like they were maturing quite well. Now at 10 weeks, this was how the tissues looked like, and they looked even better, so I knew that we were on the right track. And from the side profile, you can also see how I have maintained that labial emergence of the soft tissue as well as the hard tissue. So I was quite pleased with how everything was looking at this point of time. Patient's oral hygiene had also significantly improved as compared to immediate post-op. Now, at the 4-month mark, I then repeated my ISQ readings, and I had gotten readings of 80 to 82. So I was quite pleased with that, and I knew that we were ready to actually get our final restorations made. Now, because the patient had wanted to replace her anterior crowns, at this juncture was when I had actually removed off her existing crowns at 1.2, 1.1, and 2.2. Re-prepped those teeth in order to receive new crowns, and then I had also done the scanning of my crown preparations as well as my implant site using the Straumann BLX scan body in order to capture all of those records for my lab digitally. And upon doing that, what I had also done, which is what I regularly tend to do for a lot of my cases, was to actually take a scan of my immediate temporary provisional that I had fabricated for the patient. And this is so that my lab can actually mimic those emergence profiles in my final implant supported restoration as well. Now, the next step was 2 weeks later to issue her final restorations, and this is how it looked like immediate post-op upon issuing the restorations. The patient was quite happy with them, and so was I. So we then proceeded to close up the excess screw access holes and adjust the occlusion a little bit. As you can see, the incisal edges were a little bit uneven. The patient wanted me to actually make them straight, so I made those minor adjustments for her as well. But overall, she and I were both pretty pleased with the results. Now, as a recap, this was how we started with the immediate pre-op. And this was how she looked like at 10 weeks post-op. I was quite happy because you can see that we had maintained that gingival architecture quite well. And this is how the patient looks like at 1 year post-op now. We can see that we have maintained that gingival soft tissue architecture. The soft tissues have integrated very nicely with all of her final restorations, albeit we do still have that tiny little black triangle there on the distal of 2-1, but it did not worsen compared to how she presented pre-op, so the patient was quite happy, and so am I. And that is it for my case, guys. Thank you so much for listening in. I really, really appreciate it. And I hope you enjoyed watching this case as much as I had the time executing it. Thank you again.